Welcome everyone. On behalf of the Bevan Commission, welcome to the Enabling Technology to Transform Health and Care for People in Wales. And I think the really key word there is for people in Wales. Not two people, but for and with people. Our video there highlighted some of the excellent benefits of technology and digital technology. But notwithstanding that, it also highlighted some of the issues that we see and hear from people across Wales. These comments have been taken from reports that, whether it's the CHC report, the Community Health Council report, Digital Health and Care Wales reports, and advocates themselves, Bevan advocates, of which we have a number of key listeners here today, and they will in fact be responding to our digital leaders that we have with us for the session today. We understand that there are many people who, despite perhaps wishing to or wanting to be part of this digital decade and so on, for those, some of them who can't access, some of them won't, and some of them don't know how to. And I think therein proves some of the challenges that we have in front of us. We already know that in the region of 10% not online. That equates to 255,000 people not using digital. And of course, we see a higher percentage of people in our over 65 age group in that category. Today is about bringing some of our digital leaders together. We have a number of leaders with us, and we want to be in a position where we can explore with them some of the crucial questions. We want to challenge them. We want to understand some of the issues that they are facing. And hopefully today we want to come out of this with a better understanding, a better knowledge of what we can all do differently once we leave here today. I'd like today not just to be a talking shop. I'd like today to be something really proactive and active. And by bringing our key digital leaders with us today, we can help find some better solutions as we move on. So today's agenda really stems from some of the issues around we ensure that session makes a difference. So we'll be looking at questioning some of our participants. We'll be looking at an opportunity to question from the audience. So I would please encourage you to do that yourselves, put in your questions so that we can pick those up. We will then have feedback from the listening panel, who will be listening and observing and providing an input and an insight from a different perspective. And please, can I encourage you in the meantime to join social media as we see the hashtag there. So please, can I encourage you to do that? Our agenda today will be one whereby we can certainly understand and get behind some of the issues that we do talk about a lot. I think many of the challenges are known, but what I'd like us to do today is to get under the skin of this and to really understand how on earth we can move on from this. We've seen huge moves, huge strides in the last 18 months. We've seen huge opportunities and we've seen the opportunity to make things work. What I'd like to walk away from here today doing is having some solutions that can continue to strive and motivate and move along the digital agenda. So I'd like, first of all, really to introduce our speakers here today, our panel, if you like, who we're going to pose some questions to. And as I said earlier, they are our digital leaders across the board. So firstly, we have Professor Hamish Lang, who is Chair of Digital Inclusion Alliance Wales. Many of you will know Hamish from the past. He's had many NHS leadership positions, including Exec Medical Director within Swansea Bay. Hamish also is incredibly passionate about the importance of digital inclusion and was delighted to be elected as chair of Digital Inclusion Alliance for Wales. And he's also got many other assets he brings to the table. Many of us will be aware of, if not know personally, Evan Evans, who carries the director role for Health and Social Services Group. He has in fact quite a wide portfolio, which includes digital and technology policy, innovation, industry engagement, strategy, transformation, and many other aspects. And he is, in fact, the lead for digital elements of the COVID response. And previously, and he's very lucky to have had this one, which was the social care Brexit readiness. Congratulations for that, Evan. We also have Sally Meacham here today, who is the interim CEO for the Centre for Digital Public Services. Sally's had many digital transformation roles in both the public and the private and third sector agencies over 15 years. And recent roles include the Chief Operating Officer in the Cabinet Office, in the Government Digital Service, Chief Digital and Technology Officer at the Crown Commercial Service, and digital advisor to Essex County Council. So she brings that wealth of both public, private and third sector with her. I'd also like to introduce Paul Mears, Chief Exec of Cwm Taf Morgannwg Health Board. Paul has been Chief Exec since September 2020, and prior to this spent 2 years as an independent management consultant advising clients both in public and private health sector, as well as digital healthcare and businesses, and as a senior advisor to McKinsey & Company. Previously, he was chief exec at Yeovil, but also spent earlier part of his career in Torbay. Next, I'd like to introduce Helen Thomas, who is Chief Executive of Digital Health and Care Wales. Now, this is where it gets really complicated, and they will explain the differences between all these different organisations. So Helen was recently appointed to this position, having spent previous year as interim director of NHS Wales Informatics Service, leading the organisation impressive response to the COVID-19 pandemic, and we understand has recently won some very prestigious awards. So congratulations for that, Helen. Well done. But Helen has been involved in the NHS Wales Informatics Service for a number of years and brings that wealth of experience to the table. Now, on top of our experts, if you like, we have looming in the background what we have called our listening panel. They will be the ones who will be avidly listening to what the responses that the panel give, and they are well versed and well equipped to do so. So the first of our listening panel is, in fact, one of our Bevan advocates, Barbara Chidsey. And she is also chair of Wales Leading Wales Awards, Daring to Dream. Barbara's been a member of the Bevan Commission and an advocate with us for a number of years. And she's studying a Prof Doc at Cardiff Met, exploring the role of conversational leadership in developing patient activation. So she is also, she was an ex-head teacher of a school in Merthyr and has considerable experience as a patient across multiple clinical specialties. Barbara will bring a whole wealth and dimension to this, so she'll be listening through many facets. And finally, really, our next listener, expert listener, is Fran Target. She is, in fact, one of our Bevan commissioners and is currently an independent chair of the Welsh Government's National Advice Network, providing expert advice, guidance and support to Welsh ministers on how to strategically develop the provision of social welfare information and advice services throughout Wales. Now, Fran was previously director of the Citizens Advice Cymru, and was there for a number of years, but also she is currently vice chair, board of trustees at the WCVA, and so therefore brings this huge wealth and dimension of what it is that people really feel, see and need. So that is our panel for you today. I'm going to ask each of the panel members a number of questions. Let's see what they come up with, and we can, don't forget, you can ask questions along the way, and hopefully we can get to the end where we are better informed about how all these different organisations and agencies work together, how they all collaborate and make sure that we continue to progress, we continue to address some of the challenges that we see, particularly around the digital divide, and I'm sure that will come up in our conversation later on. But the important thing is that we start where people are at, we build on what we know works for people, we enable those who find it difficult, and we don't exclude them. Now that sounds easy as I sit here, but let's put some of these questions to the panel. So my first question, and I'm going to come to Ivan first, since you're in my top right box, Ivan. I want to know what are the key digital transformations that have been implemented in your area of work, in other words, from policy and perspective of government during the past 2 years, and what's been their impact?
So thanks very much, Helen. It's a great panel, and I feel very honoured to be on the panel with all of the other speakers. It's great to have an opportunity to talk about the last 2 years because they've been very, very busy. I don't want to go through the individual programs, and I'm sure Helen can speak to those with more detail than me. I just want to emphasise maybe two or three of the things that have qualitatively changed. Who would have imagined that we were using digital in the way that we all have as part of the COVID response? And I just want to draw out some of the things on that. In particular, I want to draw out the really profoundly preventative aspect of contact tracing and of proximity tracking. I was very closely involved in the NHS COVID-19 proximity tracking app, and working with Helen and other colleagues, setting up the contact tracing platforms that we have. They are all about stopping people getting ill in the first place, which is the opposite of where most of our systems have been in the past, which have been about enabling treatment. I think that's quite a profound shift, and I think it's an important thing that we need to play back to the population all the time, because it's always been difficult to do more on prevention, and we've done a lot more than we have in the past, and we need to hold on to some of that. And linked to that is patients being responsible for their own care in terms of, we ask people to book their own PCR test, we ask them to take their own PCR test, we ask them to report the results of their own LFT tests. So we have not been doing this in the past. This is not mediated by clinicians. So this again is a very profound change. We're moving services out digitally enabled and technology enabled into people's homes, and putting more power and decision making in people's own hands. So I just want to hold those policy things. We'll come back to maybe some of the wider discussions about how that has been enabled to happen later on. But you've got lots of panelists and lots of questions, I'm sure, so I'll try and keep them short.
Okay, thanks for that really helpful introduction, Ivan, and that reminder, of course, of that significant shift to patients and the public taking greater responsibility for their own health. Helen Thomas, sorry, we've got multiples of Helens here today. Helen, can you pick up on some of the points that Ivan referred to then?
Yeah, no, happy to, and thank you for including me in the panel today. I think, it would be remiss of us not to start with contact tracing, actually, because that was one, I think, as a digital professional, I don't think I've ever been involved in the in the delivery of a system where at the outset you didn't know what it was you were buying, who you were buying it for, how long you were going to buy it. So there's some key challenges in some of this for us in terms of how we were able to kind of embark on the delivering a solution in those sort of parameters. So a very uncomfortable position for those of us experienced in buying systems in the NHS would find ourselves. We did actually, just to allay any fears, actually, we won an Innovative Procurement Award, the best procurement response across a public sector organisation across the UK for the way that we procured that solution. So there were many kind of innovations really in the way that we deployed that. That actually is out there, and as Ivan said, the way that has actually kind of turned some of the thinking and the process on its head. Actually, it's a really clear example of that. Some of the other areas, I think, were were for me, you know, we did a lot of work with England around enabling data flows across the border. We wouldn't have been able to respond in the way that we did in terms of the use of the data and the understanding what was going on with the pandemic if we hadn't had been able to stand up those additional data flows. And I think we benefited in Wales from the strategy that we've been at this for some time, for the last perhaps couple of decades, but we'd set out that we would have a more open approach to the way that we would organise digital services and systems and technology in Wales. We were able to make use of that by moving data around the system. So things like a COVID result can find its way back to your clinical record in Wales. And that happened at, you know, at the very outset of it as we were taking off. But I suppose some of the major changes were our ability to be able to support all staff, including clinical staff, to actually work remotely. So we all embraced the Microsoft products that we already had, but we actually rolled them up. We had a 2.5 year kind of implementation plan for Office 365 and Microsoft Teams. That happened within weeks, really, across all organisations, and enabled that remote working. So I guess they were some of the big advantages, I guess, we had. And what we also did was not all of the solutions that we put in place were new. They weren't as novel as the virus was. Actually, we started to embrace and make use of the stuff that was already there and available to us. And I think that was actually perhaps where a lot of our success was. So we were able to make use of new technologies to support video consultation. The reason that was perhaps quite successful, and not just videos, remote consultations actually, because telephone worked effectively in many areas, was that there was access to clinicians to the digital health and care record for all of the residents of Wales. That was available remotely wherever that clinician was, so that secondary care consultants could still do some of their clinics, and GPs could still treat patients. So yeah, I would say those would be the highlights for me.
Thanks, Helen, and congratulations, because I think, and I'm sure for many here today, you know, a lot of this was all invisible. We didn't see it, feel it, or touch it. It was somewhere happening in the background, and that's why I think it's very good to share, to have the opportunity to share it, put it on the table, and of course to celebrate it. I suppose the big question, which I'll come to later, is so how do we build on this? How do we learn from it? But I'll come back to that in a moment. Sally, I'm going to come to you, really. You've got that wider digital public services perspective. What was it for you? What was it like for you?
Thank you. I'm very happy to say that I'm already working with Evan, Helen and Hamish, and watch out, Paul, we're meeting on Thursday. So it's a very familiar panel, and it's a really, really good start to working with health. So the Centre for Digital Public Services, I'm probably the most unknown here, has been set up in a very short sentence, to support the design and delivery of better public services. And we look at the whole service, and then why we're looking at the public sector is because services quite often go across a number of organisations, and they might touch on health, they might touch on local authorities and third sector, for example. So we're very interested in how we can design consistent, better, easy, frictionless services. We started to do discovery before COVID happened, so we weren't set up as a response to COVID. However, in the discovery, we were able to identify some really good stuff that was happening out there, but no way that we can, as I've said before, sort of share the good news, share good practice. But there was a lot of big challenges around skills, around leadership, understanding digital, and the fact that people wanted to have standards when they design and deliver services. So as I say, we weren't a response to COVID. However, the appetite over COVID for digital services, and then the absolute need to have digital services has helped, I think, the centre have more conversations and move things across and start things up more quickly. I think the impact from my perspective is that what I did see is that there was a real desire we had to deliver, and we had to deliver at pace, and some of those governance and risks not were taken away, because that wouldn't be right, but they were questioned and challenged in order for us to get things done. So for me, and there has been some great things that we can continue. I think there's some of the stuff we need to look at a bit of a retrospective of what happened over that period, and what we keep the good things and perhaps challenge some of the other parts of it. But in general, from a cultural perspective, we have moved on, and from a user's needs with regards to expectations of government and how they get their government services has obviously increased. So it's not the right thing to say that COVID was positive in any way, shape or form, but for digital services, this is a good opportunity for us to build on that. And this is what we're doing with health and other parts of the public sector.
Thanks, Sally, and thanks for highlighting the balance between, you know, government and managing risks and governance. So I'm sure we'll revisit that in a moment. But let's move on to Hamish. Hamish, really, what do you see as the key digital transformations that you've seen and the impact during these last 2 years for you? What was it? What was it?
Thanks, Helen. Well, good afternoon, everybody. I mean, I come at this really from the perspective of the citizen or the patient. And I think one of the big changes that's happened is that until now in health and care, a lot of the investment in digital was around the infrastructure to run hospitals and GP practices and community services, and to support clinicians delivering care. And there's been a huge amount of that, and it's been really positive, but there hasn't been very much that's been focused on the patient or the citizen. There have been some examples, but they were quite small scale. And what has happened because of COVID is suddenly, as we've heard from colleagues already, there's been a huge focus on doing things that were for patients and citizens to use, the COVID apps and things, for example. And so for me, one of the exciting things, your dog, is that the citizens have been really engaged, and actually we know from the Consumer Digital Index has just been published that a quarter of citizens in the UK said that they were more confident about using the internet than they had been before COVID. Although interestingly, it's only half that in Wales, and there's a bit of a theme which we may come back to around that. But people started to engage more digitally. And for me, one particular example, we were really concerned in the Digital Inclusion Alliance that we would be seeing things moving onto digital, but some of the most vulnerable people wouldn't be able to use it. And this was particularly true in care homes, where a lot of care homes didn't even have broadband or internet, never mind devices. And I was really proud to work with the Wales Cooperative Centre to help them to support a business case that went into Welsh Government. Very grateful to Welsh Government for funding it, that allowed 1,000 tablets. That's two for every care home in Wales, approximately, to be rolled out with some education on how to use it for the staff and the residents, not just so that they could have their healthcare through video consulting or engaging with their GP practice, but actually so they could keep in touch with their family as well. And so for me, that was a really positive thing. And I would just say that in the Digital Inclusion Alliance, there are over 60 organisations, from very large like BT and Microsoft through to small community organisations and some fantastic charitable organisations. And they did brilliant work supporting people who weren't digitally included to get online and be able to function, frankly, during COVID.
Thanks, Hamish, and apologies for the dog. Somebody come to the door, and inevitably the dog goes for the door. But I think, again, a very pertinent reminder: 2 iPads per, if you like, per care home. It really brings it home as to the real challenges that we had. But also, I think we must take a hat off to people such as yourselves, who turned around that business case, and to Welsh Government, in fairness, who actually turned around and made things happen. And I'm sure, we've seen lots of examples of that. I suppose the dilemma will be how we build on that in the future. I'd just like to hear from Paul now. Paul obviously was at the front end to deal with this as the chief exec of a health board. Paul, what's your take on this in terms of the transformations?
Thanks, Helen. So very much agree with the points that other colleagues have made, and I suppose from a health board perspective and the people who were charged with deploying much of the technology that's been described by other colleagues, I suppose, you know, everybody here says, you know, we probably delivered more change in the space of, I don't know, a month than we probably would have done if we'd planned for it in 2 years or so. You know, things like digital consultations, you know, we've all been having conversations about that, I guess, for a long time, haven't we? And it's been very sort of incremental, and we've had a few enthusiastic doctors that wanted to do it, who did it, and then there were others who were less keen. And literally overnight, we had to sort of very quickly switch everybody to say, right, there is no option now, we have to do it like this because of the pandemic. So I suppose a bit like Sally said, if you take any positives out of something like a pandemic, at least some of these things came about quite quickly. With that, I guess, comes also the realization that not all of our clinicians are as well adapted to technology as everyone else, you know, so we've had to do quite a lot of work, I suppose, with some of our clinicians, hand-holding them through that process, because it can feel quite uncomfortable when all of your training and your career to date has been about that personal interaction with a patient, and then suddenly overnight you're told you're now going to interact with people remotely and you're going to have to interact in a different way. It's quite unsettling for a lot of our clinicians and our staff. And I think it also flagged to us some of the work we've got to do around digital skills within our organisation to upskill some of our staff in using this sort of technology. So I think, yeah, great opportunities, and it did mean that we could carry on providing services. And equally, colleagues in primary care have the same experience. And also then, I suppose, in terms of running the organisation, the fact that we're able to move onto a virtual platform to have interactions remotely. I mean, I started at the Health Board in September last year, and to date, there are still colleagues. Helen, I don't think we've ever met face to face, yet we've had interactions nearly every week in various forums. And there are a number of my own IMs that I've only just recently started meeting face to face, because, you know, we were running the organisation virtually, and even just things like streaming board meetings live now on Teams. You know, I suppose we've talked about that before, but it's never happened. And now every health board is streaming their board meetings live. So there is something there also about the way we run organisations and the way we interact with our communities and give people opportunities to engage and interact. And it has definitely helped us as an organisation bring more people into conversations that probably we wouldn't have done if we'd required everyone to move across our geography. So I think that there's definitely a learning and that we can take away in terms of how we organise ourselves internally and how we get work done in the organisation, in taking the learning from what we've had to do in crisis time.
Thanks, Paul. And you reminded us of the fact that the other benefits, I suppose, of some of that remote networking are really around the environment, how, you know, we save travel, transportation for both professionals and the public. We speed up things. You know, I don't know about people around this table. I'm sure many people listening in today will be thinking about how many more people they can see in a day because it's remote. You don't have to travel. And interestingly, I got asked to go to a meeting in the new hospital in Gwent, and I hesitated because it would take me an hour to get there, an hour to be there, an hour to come back. That's a half a day, and you suddenly think about it in terms of other means. But we're in danger of losing that real face to face. There is something about that contact that we must be mindful of, and I think we'll come back to that in a moment. I'd really like to move on really to the next question, which is how do we ensure that the services are designed around the needs of the end user rather than the needs of the organisations? And I suppose this is but a similar kind of question around how do we ensure that whatever services we put out there is actually meeting the needs of the people that we are there to serve. So I'm going to start with Sally on this one. Sally, how do we ensure that we don't design the needs of services around the organisation, such as we've got here and the large organisations, but around real people and, you know, some of the things that we'll have seen, heard earlier, The danger is perhaps that we do it because the systems are available, the services are available in such a way, but actually we're losing something out there. What's your take on this, Sally?
Well, anybody who knows me would know that probably for 90% of a conversation I'll be banging on about user needs, and because it's really important to me, and I think it's really important to how we design and deliver services. And I don't think people disagree with that, but I think it's understanding what user research really is and how that differs from different roles. So for me, it's really critical, and we have service standards that we understand before we start anything what is the problem we're trying to solve and what is the user need for that problem. And I think if we could do anything, as long as we had those two questions before we spin up, or if we've got the time to be able to do that, because I do accept in some occasions you just need to get things done, particularly through a pandemic. But if we give ourselves the opportunity to really set up work to say, okay, what is the user need here? And one of the things that I talk about a lot about the user need and how a user researcher, for example, differs from a business analyst, is that a business analyst is very much looking at the needs of the organization and process, but I'm not saying that's all they do. And the user researcher will be looking at the behavior of the user. Where do they go to for their information? How do they interact with the information? So even though we do citizen facing conversations, what a user researcher can do in that profession is not just listen to the words, but look at how they behave and how they use services, and be able to turn those and translate those into a good and better service. So I think it's really critical. One thing is that there are not many, as I would say, and indeed digital data and technology profession framework is that there's not many user researchers as I would perhaps see them. However, there are a number of people across the Welsh public sector who are excellent, who are doing a very good job with regards to doing what they can with the data, with what they can. I think that my experience, because I've been doing this for it's actually 20 years, but I cut it down to 15 because 20 seemed like a really long time and I should do something else. But it's like, I mean, it's for many years where we look at how to really be professionals in user research, and we can't just say, okay, we're going to get rid of all of our analysts or etc. and just bring the whole load of user researchers, because they don't exist. There aren't many of them. If they exist, they're snapped up by people. So one of the things we need to be looking at is how do we upskill our people? How do we take them to the next level of understanding what user research is and really understanding user behaviors? I always think that with like a business analyst and a user researcher, there's probably about sort of 60 or 70% they're kind of already there, but there's a bit more we can do around upskilling and bringing them into that profession. So it just, for me, it's just my mantra. What is the user need here? I don't think we do enough of it. I think there's quite often a move toward a technology solution, and I'd like to, from a cultural perspective, try to kind of move away from that, understanding fully that at the moment there isn't a huge amount of skills and capability in the digital profession. So it's all very well saying we should be doing user first. We also equally need to be looking at the skills and capability and how we build our own skills within our organisations, but build the pipeline of talent through the Welsh public sector.
Thank you for that, Sally. And presumably user researchers, are they just members of the public? How do you define a user researcher?
So a user researcher is a profession. There's a people who understand how to, as I said before, how to understand human behaviours, how to ask the right questions and to listen the way that people use services, so they are able to design the most simplest service. But also, if you think about it, that they understand different personas. So if you've got a service, there'll be lots of different types of people that are accessing that service. They will help to get to a point where we can have a commonality of how that service works. Now, as Hamish would agree, okay, there's an X amount of people who can use online digital services. We try and make that as common as possible and simple as possible, but there will need to be other ways that you can access that service for people who are not online. for example. But a user researcher is a profession. You as I said, you need to understand research, but you understand people, and really need to understand how that's translated into being an actual digital service.
So what we're likely to see then is a sort of expansion of what we see as user researchers as part of moving this forward in the future. And Hamish, I'm going to come on to you as part of this, your Digital Inclusion Alliance Wales. The key here in the question is the how. We've heard from Sally, and she provided a very comprehensive reinforce the need for user researchers. What would your response to this be? How do we do this? How do we really do it in practice to make sure that it does pan out? It's not just based around service needs.
You're on mute, Hamish.
Hamish, you're on mute.
Thank you. Sorry, I thought there was another man in charge of that. There's a real risk, I think, that that we could take the inverse care law in Wales and digitise it and have a digital inverse care law. So we know that that 1 in 8 people, in fact, in the most recent survey in Wales, are not online in the last 3 months. We know that it's worse than that from a health point of view, because 40% of people over the age of 75 are not online. People with long-term disabilities are less likely to be online. People who are poor are less likely to be online, and people with low educational attainment are less likely to be online. And that group represents a big chunk of service users of the NHS. So we know that a much greater proportion of NHS patients are not online than the average. And in Wales, we have 3 times as many not online as the UK average. So there is a real challenge to get people online. I'm not advocating that we should just give up on these people and just always have a non-digital alternative. We will need to have analog alternatives, but we should be trying to help people, support people to get online, because there are some intrinsic benefits of doing some of this stuff digitally. And as with AI and machine learning, some of those benefits will become greater and greater. So the paper version will become less and less good. So the answer is, in parallel with rolling out well-designed digital services, is to have support mechanisms so that people can be helped to get online. And if you ask people who are not online why they're not online in Wales, 40% of them said if the apps and the websites they were being asked to use were easier, they'd be more likely to get online, which comes back to Sally's point. But there are other issues too. You know, a third of people say if they can't afford it. Broadband and data bundles are very expensive. So data poverty we need to try and work on. And a third of people say they can't see the point. Why would they want to be online? What are the benefits? So there's a communication issue there that we need to help people understand why it would be good to work. And then nearly half of people who aren't online say they're worried about the security of their data. So that's another thing we need to provide reassurance about. So I think it's a combination of, in parallel with rolling out digital services, is to think about digital inclusion alongside it, not just assume someone else is going to do it, but actually to work with partners. We have many who can help health services to support people, design them well so they are easier and more friendly to use, and communicate to people what the benefits are. And I think then we will have both better design services that meet the needs of people, that people that we want to use them are able to. And just to finish, there isn't just a kind of moral case about this. You know, it would be quite wrong for us to move in a way that excluded the people who are most likely to benefit from our services. And actually, if we do it right, we could close that gap. Digital done well could close the gap, not just not make it worse. So we must do that. But there's also a financial case. There is no point rolling out services digitally if the people who we want to use them can't. So we must think about digital inclusion as part of every business case for digital technology, in my view, that faces the patient. And as Paul's pointed out, this isn't just about patients. Our staff too. Many of the NHS staff are digitally unconfident, and some are digitally excluded.
Thanks, Hamish. And it reminds me, for instance, of an occasion whereby the banks, when they went digital, they faced a very similar situation. And they did two things. One, they recognised that they had transformed too quickly and that many of their staff weren't equipped to address the needs and the changes. And they then used a scheme which was using their young employees, so their 18 and 19 and 20-year-olds, to educate their slightly more mature staff. And so that worked really well. They did a rapid skills transformation there. And the other thing they did, they recognised that actually they didn't need people behind the tills or behind the screens, and they brought them outside into the foyer of banks. Well, that was when we had high street. But they brought them out into the foyers to help people use the services that they were transforming. And in fact, I remember going into a bank on one occasion, needed something, and a person just took me through on the computer how to do it. And it was really, really easy. And so I think there are some tricks in there that we've got to become a bit more savvy about. And before we move on to the next question, I just want to ask Ivan, from a policy and a government perspective, how that these services that are provided for people in Wales are designed around their digital needs and capabilities. How do you do that to ensure that we are addressing that?
So I missed a little bit of that question, Helen, you dropped out. But so in terms of a government drive, we work very the government in health doesn't develop services of its own to provide, and actually most of the services that we do provide across health are still aimed mainly at clinical users. Although increasingly, as Hamish was talking earlier, we're dialing up very significantly the services that are directed at the public and at patients generally. I think first that compared to where we have been, there's a very strong professional clinical influence across the whole of the health sector. And in the past, maybe in some of our services, we've been very willing to respond to clinical preference on a user-by-user basis, or on a team-by-team basis, or even a hospital-by-hospital basis. And that's led to quite a lot of variability. And focusing on the needs of the end user is not about the needs of each individual end user, but on trying to get underneath the way that they use tools to get a kind of a best fit and to understand properly the context in which services are being used. And I'll give you a very mangled quote at the end about if you just ask people what they want, you don't necessarily expose their needs. If I'd asked my clinicians what they wanted, they would have said a faster horse, just paraphrasing Henry Ford from a long time ago. Yeah. So there's a challenge there, and I think focusing on simplicity is really, really important. And the way that we do that is that we start to think about things in a different way. It does involve professionalizing the discipline of user research and evolving all of that, but it also just involves being very conscious of that. And certainly there's some examples of standardizing across Wales. There's got to be some confidence, I think, in this area about imposing common approaches, and certainly for contact tracing. Everyone uses the same screens, the same workflows, the same reports. That's been hugely powerful, and it was difficult to achieve that in the early days, but everything was moving at a daily sort of clock. But it's been hugely powerful in order. We've got a surge team that can be deployed anywhere in Wales. Different local authority teams can support each other when demand, because they're all using the same workflows. If one team develops some really good reporting and dashboards, we can just switch that on across the whole of Wales, and it's instantly deployed to everybody. Because we're all using the same data and we're all using the same platform. There's real power in trying to find the common need in the common platform. So I think we're far more conscious of that and more focused on it than we were. But coming back to what Sally was saying, there is a shortage of digital professionals in this area across the whole of the UK. The market is very stretched because Wales is not the only place that is trying to dial up the things that it's doing digitally post-COVID. Everyone is doing it at the same time, and universities don't churn out new skills that quickly in response. So I think that is one of our biggest challenges right now: is where do we find the talent and the people and the skills to be able to absorb all of this additional investment that we want to make in new ways of working, but also really embedding some of the changes that we've seen from COVID.
And again, we come back to the skills of both the professionals and the public. And, you know, I guess Welsh Government has the opportunity to influence and I guess to some extent direct where some of those skills needs to grow. Now, the extent, as you've said, you can't grow them overnight, but certainly we can be starting to look at how and in what ways we can refocus and speed up that transition. So thanks for that. I'm gonna move on to the next question.
Very briefly, I think I'll just mention very briefly while we're talking about award-winning things. So the Health and Care Workforce Strategy, HEIW's Health and Care Workforce Strategy, which they developed in partnership with Social Care Wales, that won an award last week for Best Workforce Strategy. That's got a very prominent theme on building a digitally ready workforce in the NHS, which is some of the questions that Paul and Hamish were referring to. So this is not just about the digital profession itself; it's about the whole NHS profession, and it is embedded. There are 7 priority themes, and one of them is digital. And we are seeing that across all of our other programs. We're seeing strong digital presence and work streams in all of our programs. It's very, very different to where it was 2 or 3 years ago.
And you know, with all due respect to everybody, we, you know, people, professionals, the public had to transform very, very quickly, probably in many cases without very basic training, but just had to learn on the job, so to speak. So I think the ability for us to be able to build on that will be absolutely crucial in the future. So Paul, really, how do we get the basics right and take the public with us? And you know, there will be challenges and opportunities. We've seen, you know, and we've heard today about some of those. But how do you do it in a positive and how do we motivate and encourage people to do just that?
Well, I think some of the points that have been made by Hamish earlier on is, I think, first of all, we shouldn't make assumptions that everybody can adopt a digital way of interacting with our services overnight. So I think there is something here about how we have a range of options for people to use. And if you look at what's happening in primary care at the moment, I think there's a lot of, obviously, you know, you've only got to read the newspapers at the moment, and a lot of unhappiness about people not being able to access. But actually, interestingly, even when they can access, feeling that they want to be seeing somebody face to face rather than dealing with someone over the telephone or virtually. So that, I suppose, gives you a good indication to some of the changes and cultural changes we have to make. But equally, there is a whole raft of population out there that is very happy to interact with their GP remotely by telephone or remote consultation because it's very easy for them. So I think we have to acknowledge the fact that everybody is going to be moving on this agenda at slightly different paces, and we need to make sure that we aren't excluding groups of people by putting in place unilateral solutions for every problem. Having said that, as we know, and you've described the example, Helen, of the banks, you know, in every other walk of people's lives, we are adapting to using new technologies for interacting with services, whether that's public services or indeed commercial services that we may be using. So I think, as you said, there's something about taking learning from other sectors of how they've managed to adapt and change the way in which people are interacting. But I also think we need to make sure that we don't we don't make assumptions. And, you know, I use the analogy of, you know, a lot of older people, we make broad brush assumptions, oh, well, older people won't want to use that. Well, actually, as we found through the pandemic, a lot of older people did interact remotely with their relatives and their families remotely using tablets. Now, I know many of us, I'm sure I'm not unique in this, had to help and coach our relatives on how to do it. But once they once they were able to start to see that, how that was working, it had a benefit. If you go on a holiday, remember those things. People, you know, you go to the airport and, okay, most of us are able to print out our boarding passes, but no, the EasyJets and of this world also have a phone number for people if they require special assistance to be able to phone up and get advice on how to deal with it, or they get special arrangements made if they're not able to do those sorts of things. So I think it's about us having to think differently about how we design our services. I think Sally's point earlier about user experience as part of that process, because we can be very good at designing what a clinical process looks like, but sometimes we don't look at it from the other end, which is, well, what would it feel like to the user? You know, for example, you know, we can design a great clinical process, but if the end user ends up having to traipse to 4 different departments or interact with 4 or 5 different apps on their phone because they're under the services of the diabetes team, the heart failure team, the dementia team, and they also want to book a GP appointment, and they've got different apps for all of that, that's going to be almost more complex and confusing than if they were just able to go to the hospital and see everyone in one location. So we've got to be careful in making sure that we don't, in our aspiration to move on this agenda, we don't leap so fast that we lose the end user and forget the purpose of what we're actually trying to do, which is actually to improve the interaction for the individual with the professional.
Yeah, I think you make a very important point there, Paul, really. And I suppose mopped up in all of that is how do we manage expectations across a spectrum? And Ivan, mentioned this isn't just every individual. There are spectrums of where people lie. And how do we manage those expectations? How do we both meet people's needs and give them choices? So it's moving them on, but also providing that opportunity for alternatives. Helen, I'm going to come on to you, and you've demonstrated some incredible developments, and rightly acknowledged for that. But how do we move this on to the next stage? Where are those opportunities, and where are still the challenges that we face?
I think that there's tremendous opportunity, isn't there? And we've kind of rehearsed where some of that kind of experience the last 19 months or so has led us to. But I wholeheartedly agree, actually, with the panel's comments, really, in terms of where we are around kind of supporting and taking the whole population along on a journey with us. And it will be a journey, won't it? And it will be that actually people will adopt and adapt to new ways of engaging with the NHS at different kind of points in that journey. So I think that there's the managing the expectations, meeting people's needs, is all of the stuff that we've talked about in terms of actually looking at this, perhaps, I won't say for the first time, but at scale for the first time, through the eyes of our service users, through the eyes of our patients, through the eyes of the public, really, and actually designing digital first services from the ground up, which is about the people, it's about the process, and then you have the technology. I guess I would add that we also then need to ensure that we kind of in the health service side of it have all of those foundations in place to ensure that we have all of the stuff that's needed under the bonnet, if you like, behind the scenes, to manage those interactions in a very different way. So I think there's a fair bit of work for us to do, actually, in terms of the ability to provide that choice. It's going to take a heck of a lot of redesign of our service models in line with kind of those digital expectations now. So there's got to be a real focus for us, I think, on how we support the change. So supporting our population in adoption of digital ways of working, and actually what does that mean across the board? And I think there's a great model in terms of the example you raised around the banks, actually, because I'd like to see our staff across the NHS actually getting out there in our communities and supporting that, working with colleagues like Hamish and the organisations that are there to support it. Actually, what great development for our staff to get out there and actually start to engage and encourage that adoption, really, with the patients. But I think there's also the support of that redesign of services out there, kind of in across our professionals, across the health professionals, and across clinicians, and our operational managers, and all of our staff out there, really, and to actually think about how we are going to do things very differently, because we can. And at the moment, I think we've got an awful lot of technology in place that runs the process, and actually some of that stuff we absolutely need, and it is absolutely needed to run laboratories and radiology systems and services, and to make sure that we can run hospitals and and manage GP practices and so on. But actually, we probably really need to rethink the way that we engage with those services, and actually start to look from the ground up at how we're going to do that very differently using digital.
I think you're right. I think we also had to be brave and bold, and we had to be courageous. We had to take risks. We had to change, the processes around which all of these things were done. We had to do it, and we did it. And I still think that there is still that danger that we might revert back to the risk-averse way in which we worked in the past. So I think there are certainly some of those challenges. And I think also you mentioned staff, but I think there are other. If you look creatively in our communities, you've got children who are really digitally literate. Why don't we do intergenerational? Why don't we make much more use of all those, school children, and we know the opportunities and the other, if you like, benefits that intergenerational stuff brings. Ivan, did you want to come back on something then?
Yeah, I just wanted to make a comment about risk averse and risk appetite, and I know I'm drifting off the questions a little bit. So I'm asked all the time, why do you think that the risk appetite changed last year? And bold and brave decisions and various other things. And my view is, I don't think the risk appetite really did change. So a couple of key things changed. So one was that under existing legislation, controls on the sharing of data were put into a different space under the Control of Personal Information regulations, and that liberated the sharing of information, and we were willing to let the privacy information follow after the action rather than doing it before. And there was in effect, there was a suspension of procurement regulations, which have got quite a long time clock built into them. What that meant was that there was more reliance on judgment than on process. And in many ways, I welcome that. I think that is a good thing. We are in senior roles, and we're there to exercise judgment. And we were forced to exercise judgment, but I think that enabled us to do so in ways that sometimes we're not under existing processes. But the thing that changed on risk for me is not the appetite for risk, but the horizon, the time horizon within which we were considering risk. So contact tracing was mentioned. We have 40 days to get it live. If you're asked to do a risk analysis of what's going to happen within the next 2 months, that's not that difficult because because you can. It's more constrained. If you're asked to do a risk analysis of what's going to happen in the next 5 years, well, who on earth knows, right? And therefore, your risk analysis comes with acres of uncertainty, loads and loads and loads of uncertainty. It's really hard to make a considered, assured decision when you're considering anything that can happen in the next 5 years. You asked me what technology is going to look like in 2030. Well, if I was to tell you it's going to look like this, then I'm going to be wrong, and I'd be, I need a bit of hubris, and I need to dial it back. But ask me what technology is going to look like by Christmas, I can give you a pretty clear idea. So I can make a much sharper decision. I can make a clearer decision. I can make a more certain decision and a more informed decision with more of the evidence available. And I think that's the key thing that changed. Amongst other things, you find out sooner if you're doing something wrong, and you have to admit that quite quickly as well. But it's much easier to make a decision on a 2 to 3 month cycle than on a 3-year, 4-year, 5-year cycle. And I think that's what changed, not the appetite.
Okay, thank you for that, and that was really helpful actually. And I'm going to come around each of the panel, and I just want a sort of a final sort of quick answer to the last question before I go on. I've got some amazing questions here for you, so I'll come on to those shortly. The questions from the audience. But what will we need to do differently moving forwards? This is here we are, and it picks up on Ivan's point now. While we can judge what we need to do more in 2 months, but what does that future look like for you? I'm really, really interested. What do we need to do differently, and what does that future look like? Sally, I'm going to start with you.
Okay. I would say that I think we are in a pretty good space, and I'm being very positive because I feel really positive. I've done this for years. For me, it's the first time I've really seen a strong move towards join up of health, local authorities, sponsored bodies, housing, etc. We've got a digital strategy for Wales, which kind of holds this together and encourages us very strongly to cooperate and collaborate. So I feel, even without that, I feel that there is kind of a real sense that we can do things together, and there is a sense that we are looking for how we can have consistent design to our services, and that's also in the digital strategy for Wales, that we're working with the CDO for Health, Local Authority, Welsh Government and CDPS, convening a standards board to make sure that we agree on what standards we should be designing and delivering services with. We won't have complete consensus because there are some services that will need different types of standards, but there is an opportunity to get a set of standards that we can design to. So for me, this is kind of being open and transparent. I think that we are getting more used to working in the open and delivering services and tweeting and blogging and talking about what we're doing. I think that's a really positive way forward. And so I feel that with the standards, with the organisation, with us working more closely together, and we meet on a weekly basis, CDOs, etc., to look at our plans going forward. I think that's a really good start. There are some really good things happening. We all know that skills and capability is the really big problem here. So we're all going to work out how we can together solve the initial the skills gap right now, but also look at the pipeline of talent coming through. So I do feel quite positive about what's going on.
Thanks, Sally. Paul, what does the future look like for you?
Well, I think big question there. I think, I'm just trying to. There's so many aspects to this, right? So there's definitely something about how we use the new technologies and digital solutions that are there to reshape the way our clinical services are delivered. So I think we need to capitalise on the momentum that's been generated over the past 18 months and push on with that. And I think it does bring about a whole different way of working. And, we've not talked in detail about any specifics, but, if you look at what's happening in radiology, if you look at what the opportunities are around pathology to move to more digitized ways of delivering services, which means that actually that is part of the solution to helping solve some of the workforce challenges we have in some of our clinical specialties, because actually we're never going to have enough workforce to meet the demands of our population in Wales, in the UK, around the world in healthcare. So we're going to have to find a way in which digital is our key part of our workforce strategy. I think we need to carry on with the more swift and rapid decision making around choosing which solutions we're going with and getting on with doing these things. We know the reality is this technology and these solutions are moving so fast that if we take 3 or 4 years to decide what we're going to do, frankly, the end users and the patients will have chosen to go and do something themselves anyway by then, and we'll be at risk being left behind. So we need to get on with that. And I think also for us as an organisation, I guess this is a challenge similarly for other health boards. I think we've got to really challenge ourselves about how we spend our capital money, because we still spend a lot of capital money propping up buildings that, quite frankly, in 10 years' time, we might not need. So my challenge in my organisation is going to be, when we look at our capital plan for next year, well, why aren't we taking a chunk of the money that we're spending on maintaining old buildings and putting it into new technology? Because actually, the investment in some of this technology for us as a health board is going to be fundamental to ensuring that we've got the right capability technology-wise to be able to do what we want to do in the future.
Really interesting, Paul. Interesting dilemma there, and an interesting proposition. I think we've barely touched on estates and all of that, but there will be an incredible knock-on effect, I'm sure, to that. Hamish, I'm going to come to you for the question that we've got from our audience, actually. How do we ensure that digital healthcare provision is made available in remote communities where they perhaps do not have a reliable internet connection? Is there a plan to improve the connectivity across Wales? This has been asked by a lot of people, apparently. You'll be well placed to answer that one.
Thanks, Helen. And I'm going to start by answering it by just a fact, which is that it's widely reported that 5% of all journeys by road in the United Kingdom pre-COVID were due to the NHS. So if we can do something to reduce some of that, and that relates particularly, I would suggest, to rural communities, then that would be a really good thing. There's a bit of a cop-out here, because a lot of broadband strategy and policy in the UK is UK-led, not Welsh Government or Wales-led, I should just say that. But the Welsh Government do have their own programmes, including Superfast Broadband Cymru, for example, which is trying to fill in some of the gaps in provision. And there are ambitious plans to try and get broadband to as many people as possible, as fast as possible. The challenge is that there's often 5% of people aren't included in that, and those 5%, a lot of them are in rural Wales. So there are alternatives. There are various schemes. I'm quite frustrated by some of it. Interestingly, in Spain, the equivalent of BT and OpenReach there, they have a policy to offer fibre to the property almost anywhere. They say it's in their business, it's in their interest to do so. It's more reliable, it's much cheaper to run. They're closing one analogue telephone exchange a day in Spain at the moment in favour of digital ones because they're 60% cheaper to run. So I think we could do better, but there are plans and there are alternatives, of course, around satellite and various other technologies, 5G, 4G, and so on. But the one thing that we could do is at least have hubs in communities, community centres, GP practices, community health provision, and so on, where at least you'd only have to go there. You wouldn't have to go all the way to your nearest major hospital, for example, to have your consultation. So there is a kind of middle ground of providing things in communities as well. But certainly in the Alliance, we're calling for improved broadband everywhere.
Okay, thanks for that. I've got a question for Helen now. Helen, how are design standards in the public sector across Wales going to be entrenched so that digital services, systems and data work interoperably? Oof.
So there's a lot of work going on within health, and we've got a lot of standards-based approach to the way that we design systems and services and how they interact with each other. But I think Sally mentioned earlier, there's now a move to a pan-public sector standards design board. I can't remember what the exact name for it is, Sally, but that way that we actually all adopt and share the set and make sure that we adopt the same standards so that we can facilitate that interoperability across the public sector. We've got to make a start within sectors as well, though, I'd argue as well, to move that forward to ensure that we've got all of our health data that is in an interoperable state and that we've got that open architecture and that standards-based approach. And that's a huge focus for us at the moment, actually, and will be for the next couple of years, really. But yeah, a real push on opening up our architecture and then making sure that those standards that we adopt and use actually are shareable across the public sector where that's applicable to do so.
Okay. Thanks, Helen. Paul, I got a lovely one for you, really, and it's about how do we embrace technology which removes the administration burden which many people working in public services face and allows them to refocus and reinvest that time into better conversations with patients and care for our people and community. So how can we use technology to take some of that bureaucracy and administration burden away?
Well, yeah, I'm absolutely on that. I still think, we talked today, haven't we, about some great advances we've made in terms of interacting with patients using technology. But candidly, we're still in an organisation where people are filling in bits of paper to ask for annual leave requests. What's that all about in this day and age? And I know we've got ESR, but then you get into the whole machinery of that and everyone says, oh, that's really clunky, so we don't use that. I think, the trouble is probably we're all guilty of it, aren't we? We've got systems that are there, to be honest, that can do some of these things, but they haven't, back to Sally's point, been designed with the user in mind. And so they're clunky, they're difficult to use, and actually people then end up don't bothering using them or revert back to a paper way of doing things because it's just too difficult to do it. So I absolutely agree. There's a whole opportunity for us to streamline the way in which we make sort of bureaucratic tasks within the organisation more simple. And also, at the risk of, talking a bit and not wanting to frighten people, but there's a whole robotic process automation that we should be looking to develop for some of the back office sort of infrastructure things. We've got a lot of very repetitive tasks in healthcare that go on behind the scenes, which are about just getting things done in a very routine way. Well, some of that could be automated, and every other sector is looking to how you automate those sorts of things. And that doesn't mean we suddenly lose a whole load of people. What it means is that we can repurpose some of the people doing those jobs to be the people who are going out, as Helen was describing, into our communities, perhaps to help coach and encourage and support people to adopt digital technologies. So it's about trying to take away some of the routine, mundane tasks from people to free them up to do things that are actually going to add more value to our organisation and to the patients, and also to give them a more rewarding and perhaps fulfilling career. So yeah, lots to do, I think, internally in how we use technology to improve and streamline what we do. Thanks,
Paul. And Eva, great question here from the audience for you. It's got your name all over it, really, but here it goes. It's how do we ensure digital approaches to delivering health services are part of sustainable change rather than part of the COVID response?
Well, I think they are going to be inevitably, because clinicians and users are suckers for bright and shiny new technology like anybody else. And I think the really interesting thing is not how do we hold on to the digital services that we've already got, because people familiarize and they adapt very, very quickly to new services, and then they want to hold on to them. I think it's more about how do we use bright and shiny new technology to drive service change and to drive change in clinical practice. And as an example, Swansea Bay has been a pathfinder for us in terms of e-prescribing in a hospital environment, and has now rolled out to all 4 hospitals. There's absolutely enormous learning about how the way that nurses and other clinicians work on the ward has been shaped by a standard digital platform, and has released up to a third of the time that previously they were spending on administrative tasks. The secret is, I use a slide with a picture of Bruce Lee. It's a quote from Enter the Dragon, where he says, he points up to the sky and he goes, "Don't concentrate on the finger or you will miss all the heavenly glory." The digital tool is a means to an end. It's a means to achieve. It's a tool, right? It's a thing that you use. It's an utility, and it's not an end in itself. However attractive it is, and however much people enthuse for wanting the new product, what matters is how it changes people's practice and how it makes that practice more efficient. And that's the thing that is sustainable. That's what makes digital worth the investment. If you're complexifying things even more by throwing digital at it, then you're making things less sustainable. So we really have to focus on how digital drives, more standardized practice, because we can't deliver on value-based healthcare and addressing unwarranted variability and more transparent data and better benchmarking across our system and more management information for planning and future forecasting and modeling purposes, unless we've got consistent practice across our whole health estate. And digital, I think, is the main tool to achieving that. And it's really important.
Okay, thank you for that, Evan. And, we've got some fantastic other questions. So the audience listening have put some amazing questions here. We just haven't got the time to go through them all. But there's a really fab one here around, are we doing enough to share best practice in the UK and across the UK? Are we doing it amongst ourselves as well? This whole thing about, how do we do this better with other people and building on what we already know? There's a whole range of questions. I'm going to promise to the audience, we're going to put them to our panelists, and we will make sure that their answers will be put onto our website. So, we will get the answers to the questions you've posed. I'm going to now go over to our listening panel, really, to get their feedback on some of the conversations that we've heard this afternoon. So I'm firstly going to go to Barbara. Barbara, give me a bit of a feel for what you've heard today and what you think about it.
Thank you, Helen, and just thank you to everyone for being invited to be part of this and to listen to everyone. It's been really interesting. I'm going to start with a challenge. Okay, I am not a user. I am not a service user. And I think we must start by changing the language. The language of user implies that patients are passive. And actually, that's part of the culture we need to change. And what we need is that patients are really actively managing their own health. And let me lob this in. The way we move forward, patients are part of the solution, not the problem, and a key to sustainability. So I had to put that one in. I really feel very strongly about it. In terms of digital inclusion, it was great to hear various points from Hamish. And I want to just flag in, because I've got experience with this, which is really beneficial as well, working on a project from a charity perspective linked up with Digital Communities Wales. I think we've got to link up more and more with the third sector and community groups to actually help include everybody digitally. I love the fact that, Ivan, you spoke up very strongly. Can we please have common and consistent approaches across all the health boards? Please, can we do that? Then you don't have all this fuss about sharing best practice, Helen. You actually put it together and do similar across. Another point I want to pick up from Hamish really quickly. He spoke about the use of digital stuff from the process strategic point of view, what I would call the macro. From a patient perspective, what matters to me is my patient experience. So you've got different things, and that's at the micro level. You've got different things for the digital elements to really enhance, but do differently. And Helen, I like the point that you said that some of your best wins were literally just by unleashing and running with the stuff you were already doing or the tools you already had. As a believer in appreciative inquiry, maybe what we could do going forward is focus on the stuff that's really, really working and do even more of it. Ivan, you picked up, please learn from the private sector. I beg you all to learn from the private sector and work with them and not criticise them. And my final point, which in effect Paul just said in a different way, please, 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 less is more. We can't do it all. We've got to filter it down, focus what we're doing and go forward. Thanks, Helen.
That's a really great overview and some very poignant messages there at both the beginning, I'm not a user, and the end. Really, really excellent. Thank you very much for that, Barbara. And I'm going to come to Fran now. Fran, we'd like to get that feedback from you. Where have we got it right? Where are we going? What are the opportunities, and what did you hear about our next stage for this?
Thanks, Helen. I hate going after Barbara because I was then ticking off all the points that I wanted to make. So I can't disagree with what Barbara has heard. And I just want to thank the panel because it's actually been a really fascinating discussion. It's a tricky area. The thing that really I felt came really strongly through from all of you was around thinking about people, thinking about what do we need to do that actually makes patients and people access the services better. And there was that whole thing about user research. Now, I would suggest we actually want user co-design, because I think that just having user research isn't going quite far enough. I would challenge you on that. And I also think there's that interesting piece about those questions that were being fed back to us about people worrying, what worries them. I think you talked about things like some people actually who don't use the IT systems, are worried about their data and protecting their data. I think that's an important one that we've got to overcome, but we've also got to overcome actually accessing our data. And I'm interested that nobody mentioned patient access to their own data, which I think is one in the digital field that we could really make a difference on. You won't be surprised that the bit that worries me most is who we leave behind. The reach of this, and that isn't about, in my view, training and digital skills and having access to the hardware necessarily. It's also additionally about digital poverty. So you can't just give people, everybody gets a laptop or whatever. You've got to pay for their broadband, and that is a major problem for the whole of public service, not just for health. And so we have got to make sure people aren't left behind. And so while you were all saying that we need other ways of access for people, it has to be of the same quality and the same speed. So we need to think really carefully about how that hybrid works together. I was just interested in some of the things that were being said about, are we making the experience better? And I think, I'd echo what Barbara said about common approaches, but I was also interested, Paul, you talked about, having to go, we don't want to make people go to various apps because they could go to the hospital. Well, I'm sorry, people don't go to the hospital and see all those specialisms on one go. They go to the different ones each time. I know I go to hospitals on that basis. So actually, let's make that joined upness about treating the person and not their individual bit of illness more important when we design the digital. So I think you had some real ideas about we must do that, but we can't base it on what's going on in the non-digital world at the moment. I also was interested, there was quite a lot about enabling self-management, especially at the start. I mean, Ivan, you were talking about some of the things that have happened over COVID. And I do think that's one in terms of doing co-design, co-production, enabling self-management is going to be really, really important as time goes on. We are going to have to move more into prevention, and that really does lend itself, I think, to this environment. But I suppose my sort of final thoughts are that we mustn't absolutely, as was stated in the presentations, we mustn't widen health inequalities. That's the most important question as we look at introducing and enhancing, or indeed just using efficiently what we've already got in place in terms of digital, both internally within the service, but also in engagement with patients and people. The most important question is, does this or doesn't this widen health inequalities? And if we started with that, we'd be a long way down actually trying to know where we can narrow those gaps. But I just found it a really fascinating discussion. So thank you all very much indeed.
Thank you, Fran. Thank you. And can I just bring the session to a close, really, with just some final remarks? And firstly, thanking our panel members. I thoroughly enjoyed the questions and the discussion. I enjoyed their comments and their interpretation. I think we would really like to see this carry on, and I noticed that you're meeting outside of this session, but we genuinely would like to see that really great link up across all of your interests in this digital arena. So from our point of view, really encourage you to continue this conversation outside of the session, but also encourage our participants to continue to question and query, whether it's on behalf of their own professionals, whether it's on behalf of their own patients. At the end of the day, we all really want to get this into a better place. And without challenge, without, if you like, people getting involved and identifying some of the issues, we will continue to make the same mistakes. I think the question that came up about how good are we at sharing best practice, whether that's internationally, whether it's across the UK or indeed across Wales. I think we need to get better at that. I think we also need to use the assets that are in front of us. We've heard that today. And the assets of not just the organisations, whether they're the organisations we've got here today, but the assets that we have in our communities and in our people. This isn't always about, as I think somebody said, user researchers are fine, but actually there are others that we can be tapping on and skilling on. We need to learn from our private sector, and I think we've still got a lot to draw in from them in this space. Digital poverty has come up, whether it's a digital inverse care law or whatever, we will always have to be mindful of that and find different ways and different solutions. And before I leave, I will just share with you a personal experience I've had recently with somebody very close to me who had a stroke, and as yet nobody has laid hands apart from the hospital, but nobody has yet laid hands or eyes and looked him in the eye and said, "How are you doing?" Digital has got some huge assets, huge opportunities, but we must not lose sight of the human aspect of that feeling, touching and looking at our patients and understanding what it is they're telling us that maybe we don't pick up in the digital context. So, you know, let's not throw the baby out with the bathwater. Let's make sure that we retain that real compassionate care, you know, in ways that we can manage and adapt, and make sure that we get that balance right between using digital technology in ways that, goodness, will speed up and ensure you know, much better and improved care, but also with that human touch and that real human aspect to, and I'm sure many medics will say this is what they were trained for, to look in the eyes of patients and to help them, support them. So again, so for me, it's about, much of this is about addressing things that we have been looking at, you know, whether it's the challenge of integrated care, whether it's looking and developing new skills, whether it's addressing new ways of working or new opportunities. And again, it's ensuring that whatever we do, we get that balance right, and we make sure that we are taking people with us in ways that we can manage for the future. We shouldn't compromise our future. We should look for those great opportunities. I think that we will see big changes in our estates as our technological skills and as our capabilities in this area develop, and as we become more confident and more competent in these. So can I finally say thank you to everyone. We will be answering all the questions that you've posed to us. They will be going onto our website. And can I encourage you all to continue to develop this field, get it right with us. Really important that we see the agencies that we've heard from today really working with people in Wales. Thank you all very, very much for your time today. Thank you.